Good evening all. Today we are going to discuss about central serous choroidoretinopathy. CSCR, which is also known as CSC, means central serous choroidopathy, or we may call it also as central serous retinopathy, characterized by serous detachment of neurosensory retina in macular region. It is not compulsory that there is a detachment of retinal pigmental epithelium here. So you may note that here we are seeing that central serous choroidoretinopathy. Here only you understand there is some problem in the choroidal vessels and there may be detachment of the retina. So what are the risk factors? Risk factors: age 20 to 50 years are more susceptible, and males are more prone to get this CSCR. And steroidal intake means there may be immunocompromised state due to the steroids, and this may be the risk factor. And emotional stress and SLE is autoimmune disorder, so it may also lead to central serous choroidoretinopathy. Pregnancy in third trimester, it may also cause CSCR, okay, because at that time uterus enlargement is very large and there may be edema at that time, and there is also increase in the permeability of the choroidal vessels there. So pregnancy is also a risk factor. Cushing's disease, due to the increased cortisol, means increased steroids, which may lead to again immunosuppression and everything. So Cushing's disease and steroid intake means steroids increased in Cushing's disease. So this also has risk factor, we can say. Pathogenesis, most important theory we accept is choroidal vascular hyperpermeability. What will happen due to sympathetic overstimulation, sympathomimetics? So there will be increased vascular permeability. So in the case of there will be dilatation of the vessels, and affects its auto regulation. Thus there is increased hydrostatic pressure will be there in the choroid, which cause pigment epithelial defect. So there may be if now there is increased pressure, this pressure may cause break, okay, so there may be breach in the outer retinal barrier. So the fluid which is present may leak through that breach, so result in the serous detachment of neurosensory retina. Did you understand it? And we can correlate with the clinical findings with indocyanine green angiography findings. Okay, we'll come to that picture later. So what are the clinical features? How the patient will present? Means they will complain of sudden painless loss of vision. So we should be more careful. There is no pain. Suddenly the patient complains of, I can't able to see anything. Like the visual acuity may be 6/9 to 6/24, and relative positive scotoma, micropsia, and metamorphoxia may be also present. Okay. Scotoma there may be darkness, and the patient may see full dark, or he can't able to find the vertical and horizontal lines properly, and there may be curving of the lines may be seen. Okay, mild elevation of then what are the signs? Signs we'll do through fundus examination. It reveals mild elevation of macular area, and which demarcated by circular ring reflex. Small yellow gray elevations may be seen. Okay. ఎందుకు ఇట్లా అంటే డ్యూ టు రెటినల్ పిగ్మెంట్ ఎపిథీలియం డిటాచ్మెంట్, ఫోవియర్ రిఫ్లెక్స్ విచ్ ఇస్ absent, okay, or distorted foveolar reflex. Subretinal deposits may be seen. There is a retinal detachment, no, the space will be occupied by some deposits, they may be seen. Okay, multifocal pigmentary changes suggest chronicity. This is a fundus photography showing the central serous retinopathy. Are you able to observe anything here? So the gray yellowish kind of thing. Okay. So coming to clinical course, CSCR, it is self-limiting. So, okay, but it is recurrent. Okay, self-limiting means no need of treatment; it will resolve itself. But chance of getting CSCR are recurrent. Okay, there may be acute and chronic CSCR. Acute CSCR, there will be short clinical course. So spontaneous resolution will occur within 3 to 6 months. Okay. and recurrences known in 30 to 50% of cases. Chronic CSCR, chronic means it lasting more than 12 months. Okay, so diffuse retinal pigment epitheliopathy, we can call it as DRPE. So affects individuals more than 50 years of age. So permanent visual impairment will be seen due to the retinal pigmental epithelium atrophy and photoreceptor degeneration. Next is bullous CSCR. Bullous means bulla. Bulla is larger, right? So characterized by larger and numerous areas. There may be many areas of serous retinal and retinal pigmental epithelial detachments. So we can confuse with the bullous retinal detachment. Okay. RPE detachments, these are whole retina getting detached like that, we can confuse it. So investigations, first anything we will do FFA, fundus fluorescent angiography. So we'll do with we'll find the two patterns of progressive leakage and pooling. So the patterns are known as ink blot pattern and another one is smokestack pattern. Ink blot pattern, ink dot, like a small hyperfluorescent spot will be seen which gradually increasing the size. Next one is smokestack. Smokestack means it is also first appear as a small hyperfluorescent spot. It appears as vertically, it will grow and like an umbrella, like mushroom or umbrella configuration, it will grow gradually. Okay, so you see this picture here, you see this is ink dot. Okay, here you see mushroom. So first it is appear as like this only, that dot, and it gradually progressing laterally and it is becoming as umbrella or mushroom. Okay, then ICG shows hyperfluorescence due to choroidal hyperpermeability. Okay, means indocyanine green. Okay, it may show hyperfluorescence due to choroidal hyperpermeability, like this only. This, okay, this picture. So coming to OCT, optic coherent topography, it shows neurosensory retinal detachment and accompanying the small retinal detachments of RPE. I think this is the OCT picture. Sorry, this is OCT picture. Okay, here you can observe. Okay, detachment is observing. Okay, on OCT. So normally this whole thing is detached. Like it should normally like this, but it is getting detached. So coming to differential diagnosis, include serous detachment of sensory retina in macular area. These may include optic pit, idiopathic polypoid choroidal vasculopathy, macular hole with serous detachment, choroidal tumors, and pigment epithelial defect. Okay, the differential diagnosis of CSR which may produce serous detachment of sensory retina in macular area. These include optic pit, idiopathic polypoid choroidal vasculopathy, macular hole with serous detachment, choroidal tumors, and pigment epithelial defect. Okay, treatment conservative, we before only saw it is self-resolving. So 90% cases it is self-resolvement. Visual acuity may normal or near normal within 1 to 6 months, and approximately 20 to 30% cases will have one or more recurrence. Okay, so steroids, if they are using, they should discontinue it, and symptomatically we can do like if there is Cushing syndrome, so we will advise the patient to reduce the weight, and steroidal diet we should inhibit, like don't take over excess of fats like that. So next, lifestyle changes. Okay, laser photocoagulation, which is indicated in long standing cases, patients having the recurrent CSR with visual loss, patients having permanent loss of vision in the other eye due to this condition. There may be recurrent CSR with visual loss, then we will prescribe the laser photocoagulation, and there may be permanent loss of vision in the other eye also due to this condition. Contraindications, there may be leak near or within the FAZ. Coming to photodynamic therapy, maybe it is beneficial for those with severe disease. So who are not means not resolved after conventional laser treatment, we can do photodynamic therapy. So example, the patient may present with signs like subfoveal leaks, and in some chronic cases we will do photodynamic therapy. Okay, after, if laser is not working, we will do that. Okay, anti-VEGF. So if neovascularization is developing, we will do we will give anti vasoendothelial growth factor, so that there will be no proliferation of the vessel, okay, which may lead to problems. Okay, thank you guys. Thank you for listening to me carefully. Thank you.